Welcome to Mind Your Mental Health channel, a channel for mental health awareness, psychological health and well-being. In this episode, we are going to talk about a psychological disorder called hysteria, popularly known as hysteria. Nowadays, we don't use the terminology as hysteria, and now it is called as dissociative disorder. I'll explain to you about that, why we are not using the name hysteria. It is a Greek word. Hysteros in hysteria means uterus. Hysteria means wandering uterus. That is what the disorder is about. You might be wondering, we are talking about psychological disorder. Where is the uterus and what is it, wandering uterus? I'll explain to you about that. Hysteria presented with different symptoms. They might have loss of function of one arm, or they might have blindness, they may not feel the sensation, or sometimes they can have what they feel like something blocking or choking in their chest or in the throat, not able to talk, not able to walk, they will be wobbly. This is a symptom of hysteria, early days. I'm talking about very ancient days. And then they try to look at the reason why this is coming. And one of the observations made during ancient days, I'm talking about centuries ago, when there was no much of scientific development, they thought this particular condition was seen only in women. Now, which was disproved later. They thought it occurred only in women. Then they started trying to reason out, so if it is happening only in women, not in men, what is the difference? So why it is happening only in women? That means there is something related to the womanhood. Then they realize that, so uterus is one organ which is not there in the men, it is there in the women. So they came up with a theory that uterus gets detached and wanders in the abdomen and comes up to the chest and chokes them here. That's why they termed it as hysteria. What it means is wandering uterus. So wandering uterus in a lady comes up and chokes her. That's why she feels choking sensation. She's not able to talk and she becomes very wobbly. So they explained the whole symptomatology with the knowledge they had at that point in time. Then later on, many studies and clinical observations proved that it is not confined to women. It can come in any gender, either a male or a female. So that was the later on finding. So then they started questioning the term itself. But the terminology of hysteria probably lasted till probably 30-40 years ago. When I started my training in about 45 years ago, we were diagnosing hysteria, different types of hysteria. So that is the historical factor about hysteria. So the hysteria terminology has become very pejorative, and that's why they dropped the name, that particular hysteria name, from the classificatory system. None of the latest classificatory system, we have two systems, I've done an episode on that, ICD and then DSM. Both of them do not use the term hysteria, it is for the past. In the place of hysteria, to explain a similar disorder and few more disorders belonging to that category, now we call it as a dissociative disorder. The next question is, what is dissociation? So if you want to explain about dissociation, we need to understand association. So association is the link between two concepts, two things or two happening. So two things are occurring together and there is some kind of a connection. So that is association. When the connection is gone, the connection is broken, then we call it as a dissociation. Dissociation is a very common term, use it a different connotation. When we come to explaining about the dissociative disorder, we are talking about different aspects of the mind. Different aspects of the mind getting dissociated, or a person getting dissociated with the reality. I'll explain to you a little more with an example. So I'm going to give an example of an hysteria patient, what we have seen ages ago, and I'll explain the concept behind that. So there is a condition called hysterical conversion disorder, in which a patient can develop a neurological deficit, not necessarily because something happened in the brain or some pathology in the brain or some kind of a malfunction of the brain. It is purely psychological. This can lead to neurological symptoms like paralysis of one hand. So if I develop hysterical conversion disorder in the form of paralysis, let's say my right hand, it will not work. So for me, it is a paralyzed hand. So I won't be able to move, I can't do anything, I can't write, I can't hold anything. So that is a symptom they have. So define the hysterical conversion disorder or a symptom, what I given as an example, a symptom without a cause. What it means is the symptom which has been developed in the patient, there is no fundamental or underlying cause. It is not because of the nervous system going wrong or some of his nerves getting affected or brain getting affected. It's purely psychological. So there is no bodily cause for the symptom, so the paralysis symptom. And it is precipitated, it is caused by some psychological or intrapsychic conflict. So psychological conflict or intrapsychic conflict. So the conflict between different parts of the mind, different processes, that leads to anxiety. That anxiety and the energy leads to symptom. I'll give an example, then you will understand. And the patient who develops this symptom is not aware of the intrapsychic conflict. The psychological conflict, patient is not aware. So patient dissociates with that intrapsychic conflict. And the symptom has a symbolic meaning, the original problem, the original psychological conflict or original psychological or the intrapsychic conflict. Let's take an example. A young student, a brilliant student in a classroom, and always stood first in the exams, and one of the model student, the student is preparing for an exam, and it is a crucial exam, and with this exam he has to pass, but he has always been able to secure the first mark or second mark in the class and doing extremely well, getting distinctions. And tomorrow is the exam. He is preparing, but as he is preparing, he is losing his confidence for several reasons. Probably his concentration was poor, he was distracted with something, or something happened. All those things can lead to a situation where he is aware that if he attends the exam, he is going to fail because his preparation is not that good. So he hasn't been preparing well, and even though he was a brilliant student, this time he feels he is going to fail. So his confidence is gone completely. And there is a conflict in mind. How do I manage this? Now all my friends, my parents, everybody think that I'm the brilliant student, and they don't have any doubt that I'm going to secure a first mark or second mark in the class. And here I haven't prepared. And if I appear for that exam, I'm going to fail. What do I do? And I can't go and tell my parents, I'll be letting them down. Now they're going to be quite stressed about it. So shall I just keep away from exam? I just don't go to the exam? How can I do that? I'm the model student. Now and the teacher, parents, everybody thinks I'm the best student, and they will not expect, even in their dream, that I'm going to absent from an examination. So that is the conflict which is going on in that student's mind. So quite concerned about it, and the student in a catch-22 situation where he doesn't want to go, but at the same time he can't stay away from the exam. With that feeling, and then with a little bit of distress, and he goes to bed. He sleeps throughout the night, and he gets up in the morning around 6 o'clock to get ready for the exam. And as he gets up, he realizes that his right hand is not moving. He's not able to use his right hand. Now he's trying to hold things, he's not able to hold, and he's trying to raise his arm, he's not able to do that. So it looks like his right hand is paralyzed completely. And he gets up, walks around, and then parents come and ask him what is happening. Then he says, I'm not able to use my right hand. It's paralyzed, completely gone. I'm not able to use. Everybody around him panics. One concern is he's got something very serious. Paralysis in a young student is quite a serious matter. So he's lost the function of his right hand. And another worry is he's got exam today. Now, so that leads to a lot of situation there, lots of discussion, the other things. And then the parents say, we'll have to look into your physical health problem. We need to look into your health problem now. Now you're not able to write. How will you write at the exam? Now, I know you are prepared well, you will score excellent mark, but you are not able to write. So your hand is paralyzed. So we need to see the neurologist, go to doctor and find out what is happening. That is the most important thing we need to do now. So don't worry about the exam. So we will talk to the teachers, the school management will explain to them. So we will take care of that. Now what we need to do, take you to the hospital and see what is happening. Now we are quite concerned with your health rather than your performance in the examination. So he goes to the hospital. The hospital is seen by the seen at the A&E. The initial triage takes place, and then they don't find anything suggestive, any kind of what we call as organic. Organic means physical reason. So his nerves are fine, everything is fine. Anyway, they want to refer him to neurology because any paralysis, it is a neurological problem. So it needs to be seen by a specialist. They are neurologists. So neurologist examines him and then does all the tests possible and then everything. Then he's not able to find out any reason. Because when he tests, the neurologist testing, he realizes that his nerves are normal, his sensation is fine, and the distribution of paralysis is not the kind of a distribution we see in a paralysis which is due to some defect in the brain or defect in the nerve. So they think there is no underlying physical reason for this paralysis. So that is hysterical conversion disorder. Then what happens is neurologists will refer him to a psychiatric department or mental health services for further assessment from that angle, from psychological angle. Okay, this is the situation, this is the clinical picture of a brilliant student developing paralysis of the right arm. Now let's go back to the explanation or definition what I gave. Now, what I said, the first part of the definition is, it is a symptom without a cause, without an organic cause or without a physical cause. So here is a paralysis as a symptom without a cause, without a neurological cause. So neurologists done all the tests and they've ruled out any kind of a nerve problem. It is nothing to do with the body or brain or a nerve. And precipitated by an intrapsychic conflict. Here the conflict is whether to go to the exam or not. If I go to the exam, I'm going to fail. How will I face my parents and teachers? If I don't go to the exam, again, how will I face my parents and teachers? Now I'm letting them down. So caught between the two, that is the intrapsychic conflict the student has as he goes to the bed. And it is a psychological conflict. Now with this conflict he goes to bed, and then when he gets up in the morning, he develops the paralysis. And he is not aware of intrapsychic conflict, what is going on in his mind. All simple for him, simple kind of understanding is, I haven't prepared very well, nobody knows about it. If I go to the exam, I'll fail. I don't want to go, but I'll have to go because I can't let them down. That's all. What that thought has produced psychologically in his mind, he is unaware. He doesn't know. So the patient is unaware of the psychological conflict. Then that leads to a symptom which has a symbolic meaning to the original problem. Original problem is writing exam, and he is a right-handed student. So if he goes to the exam, he has to write the exam in his right hand, and right hand is paralyzed. So do you understand the flow of the definition? Symptom without a cause, without a bodily cause, precipitated by intrapsychic or psychological concept, and the patient is not aware of that, what is happening in the mind. That's where it's dissociating, and that conflict has produced a symptom as a right hand paralysis, which has a symbolic meaning, the original problem, that is writing an examination. So that is the explanation was given by psychological theories in the past. Now I mentioned about intrapsychic conflict. What I mean by intrapsychic conflict is, as defined by, as hypothesized by Sigmund Freud, we have different component of the mind, ego and superego. I have done an episode on that. I think it is episode 10. So if you go back to our playlist and look for ego, superego, I have done a full episode, half an hour, probably 20 minutes, half an hour episode on what is what is ego, what is superego. And that will explain the intrapsychic conflict. Now, I'm going to tell you very briefly in a minute or two about ego, superego. Id is something which acts on pleasure principle. This is what I want it, I want to get it immediately. So it doesn't bother about anything else. Ego is something which tells us about reality of the consequence of an act. If we want to do something, the consequence of the act is given to us by ego. Superego is the one which tells you what is right and what is wrong, like what we can call it as a moral mind. Now, moral standard, moral and ethical standards, all those things. So all the time the ego and superego are in conflict. In this situation, it tells him, don't go to exam. That is a simple solution. Now if you don't go to the exam, so you're not going to fail. You just missed the exam. That is the basic desire or the pressure to do or achieve things. Now ego tells him, if you don't go to the exam, this is what's going to happen. People are going to think bad about you. If you go to the exam and fail, again you're going to let down people. So there is a conflict, to go or not to go. There is a mind pushing or pulling him towards not going to the exam, other mind pulling him towards going to the exam. So that is the intrapsychic conflict we are talking about, and that conflict had produced the symptom. When we come to psychology and psychiatry, when we talk about dissociation, we are talking about dissociation between the different components of the mind or reality, dissociation or disconnection with the reality. That's what the dissociation disorder is. And it can be manifesting an identity, what we call dissociative identity disorder or dissociative amnesia, and there is also another condition called depersonalization and derealization. I'll explain about that one by one. So let's first take up the dissociative neurological symptom disorder. The example I gave is a neurological symptom, the paralysis of the hand. So when a patient develops that kind of a dissociation, that kind of a problem, then we call it as a dissociative neurological symptom disorder. It doesn't mean there is a neurological problem. It doesn't mean there is a nerve is affected or brain is affected. I know we are talking about psychological mechanism here. So what are the neurological symptoms? Any symptom can happen. Now, paralysis is one. The anesthesia, like going numb. Now they may say that I don't have any feeling below the wrist. Now I can't touch anything. I don't get the feeling, and the sensation is gone. It's completely numb. All the tests will reveal that intact nerve. There is no neurological problem. Again, it could be psychological. People can go blind psychologically. They can actually see, they can actually perceive the colors, everything, but in their mind they are blind. Remember, for the patient is a real symptom. For a psychiatrist or a psychologist, will know that it is not neurological, but still we need to be concerned because patient suffers. For patient it is a real symptom. Okay, so one group is dissociative neurological symptom disorder. Another group is called dissociative amnesia. So amnesia is memory loss. Memory loss can happen due to malfunction of a brain, so head injury or some tumor in the brain, depending on which part of the brain, or dementia. Now very classical examination, dementia. So they start losing the memory. So some psychological trauma could have led to amnesia for that particular event. Suppose I have encountered an extremely disruptive, extremely traumatic experience. Then one of the defenses, I might forget the whole thing. So I might go into amnesia. So it is called dissociative amnesia. I may not remember whatever happened after that. It is not due to the defect in the brain. It is due to the psychological phenomenon. Sometimes we call it as a protective phenomenon because it's so painful, I forget. Now it's just gone. So that is called dissociative amnesia. Then there is the trance disorder. Now, trance is, we know the term, what is trance is, where momentarily a person dissociates or goes away from the reality. So it can happen in hypnosis. We can induce a trance under hypnosis. Now, a hypnotherapist can induce a trance where the person dissociates. So that is, if it is kind of a precipitated by psychological factor, a trauma or whatever it is, then we call it as a dissociative trance disorder. Now in the trance, they might function, they might be talking to you, but they might completely detach from the reality. So trance-like situation happens in many a time in a normal life also. Now dissociation itself can be a normal phenomenon. I'll give you a couple of examples. Now we are going on a long drive in a long route, and I already know the place where I'm going to reach. Let's say I'm driving on M1, now motorway, and from my home, the place I'm going to reach, I know it thoroughly. I have been there 100 times. So what happens as I start driving, at a particular point, I may not focus on many things. I might start thinking about something, or what is going to happen, or yesterday something, but still I'll be aware of the traffic. Still I'll be aware of the dangers of the traffic. Now if there is a red light, I will stop it, but I will not be immediately in touch with the kind of what is happening. So that part where you detach yourself and then immerse, that is a kind of a dissociation. So that can be a trance also. Religious functions and religious places can induce trance in people because they go with a preformed idea, and the religious fervor is there, that feeling is there. With that, they go in front of when they enter that religious place, they get that trance-like feeling. They might identify with the prayers and the priests and the God themselves. So momentarily they might dissociate, detach from the reality. That can happen, but it lasts only for a few seconds, few minutes, they come back. All these normal dissociative trance-like states only last for very, very short time, they come back. When it lasts longer, due to some other psychological trauma or psychological mechanism, then we call it as a disorder. Okay, then under the trance, we can also diagnose something called a possession trance disorder. So possession trance disorder is where patient gets possessed by something. Now it depends on different cultures. Now there are certain cultures where whole community might believe in possession. They might be possessed by a person who have already deceased and gone. Dead person can come on to that person and possess that person and then talk like that person. So this is a possession states. We can see that in some religious functions, not only confined to religion, we can also see that in a huge concert. Now, let's say Michael Jackson concert, now where the whole crowd goes into some kind of a trance, some kind of possession, they act out, they freak out, all those happens, sometimes without realizing what is happening to them. Sometimes they come back and look at the video clip by friend and they say, did I do that? So that is the trance state, and when it comes on as a possession, possessed by somebody else, possessed by a religious head, or possessed by a god or goddesses, then it becomes possession syndrome, or we call it the possession trance disorder. Then next dissociative disorder is called dissociative identity disorder, where the identity is lost. I am Soundarajan, I am a doctor, I practice or I attend NHS, so this is my identity. Now during the dissociative state, I dissociate from my identity. I might forget, not in organic sense, not brain wise, psychologically, and I might take another form, another name. So I might lose my identity completely and I might say I don't know who I am, or I might take another form. I might say I am John, and somebody says no, you're Soundarajan, no, I'm John. Now I come to this place only about a couple of hours ago. I come from London or Birmingham, so I need to go back. They might say, no, you're working here, you're working in NHS, you're a consultant psychiatrist, and this is your house, and no, you're mistaken. My name is John, I need to go back now. So that is a kind of a identity. Now dissociation happen. And they can also take up multiple identities also. So, and in this, we used to have a name fugue state. Fugue state is where they take a different, they might go away from the place. Now, from the home or from the office, I'll just dissociate and I don't know where I'm going and I'll just walk away. I'll go away, I can go for short distance, or I even go miles and then go to a new place. Suddenly I might come back to my senses. I might realize then I realize, where am I? Why did I come here? So that is a fugue state. So these are all dissociative identity disorder. And then we have a condition called depersonalization or derealization. Depersonalization is something which happens to the person. Derealization is something which happens to the surrounding. I'll explain. Depersonalization is where you feel you have an as if phenomenon. What is as if phenomenon? Is as if something is going wrong, as if I'm changing, as if I'm looking at myself from the top. Now that is one of the way they tell you. No, I'm feeling strange. Now that is a depersonalization. Derealization is something surrounding me is changing. It doesn't look the same place. I'm in the same home, but it looks different. Now my surrounding has changed, and it looks unreal. No, it is not real. So something is going on. That kind of feeling. So depersonalization and derealization is also part of a dissociative disorder. Next question will be, what are the causes? One explanation is psychological. Now, psychological mechanisms, intrapsychic conflict or psychological trauma or extremely stressful situation can lead to dissociation, where the situation is unbearable. So some kind of a natural phenomenon or mechanism kicks in and then makes the person dissociate with that painful situation. That is a kind of a defense system. So when that goes beyond certain limit, then it becomes abnormal. There is also some of the research point out that it can run in families. There might be some genetic factor. When I say genetic factor, when I say it could be hereditary, I don't mean it is hereditary in such a way that a parent has, children should have it. Not necessarily. A person can inherit a propensity to develop a dissociative disorder, and if the circumstances are to that level, then he will develop. Otherwise, he may not develop at all. Or even with the situation, the trauma, I think they may not develop. So there are many factors kind of leading to this kind of a disorders. So genetics and social factors, psychological factors can contribute to development of this disorder. Next logical question is, how do we treat them? Now, some of the dissociative states, I said it could be normal, it could be just more than normal, becoming abnormal, but still accepted as a normal. Now, so depends on the cultural belief. The whole community in my village believes in possession, believes in a dead person descending on somebody and possessing him for a short period to convey some messages. If everybody believes, then they may not think it is abnormal. They might think it is normal because it's going to last only for a short period. As far as it's not affecting them personal life, as far as it is not causing any damage to them or others, it is not risk, then they may not even require therapy. That we need to weigh different factors before we say that there is no need for a therapy. But psychological services say we need to assess. But culturally, the community might say there is no need for assessment. This is normal. This is normal in our culture, in our community. Then there is a conflict there. So that is about the management. So suppose patient has been visits hospital, referred to mental health services, a diagnosis has been made. Then we are talking about therapy. Most effective therapy is psychological therapy. Now, so medication do play a role. I'll come to that a little later. Psychological therapies help them. So psychodynamic psychotherapy, what we used to kind of use it in the past, even now also, which looks at the dynamics of the mind. Now, why this has happened? They trace them back to the origin of the problem. Now, they get extensive history, they have extensive conversation with the patient, and then offer the therapy. So, psychodynamic psychotherapy is helpful. And cognitive behavioral therapy, which is helpful for many psychiatric disorders, can also be used in this situation to help the patient. And supportive psychotherapy, depending on the problem they have, supportive psychotherapy can also be very helpful. And in the past, people have used hypnosis, and there are many techniques they use, but we don't use nowadays, especially in NHS, because there is no evidence base to use those kind of a therapy. Then coming to the medication. So there is no kind of a medication to prescribe to do away with this problem. So medicines could be helpful in preparing the patient for the therapy, number one. Number two, accompanying anxiety, or they might have, in addition to dissociative disorder, they might have anxiety, they might have panic attacks, or they might have depression. So that can be treated with medicine. In that way, we can treat the associated problem and the psychological disturbances produced by dissociative disorder with medicine, but ultimately the therapy is the one which is going to help them. Earlier, many of these conditions used to be treated by psychiatrists or psychologists. In the past few decades, things have changed, and it goes to a specialist area called neuropsychiatric services. One of the hysterical conversion disorder is seizures or epilepsy, like throwing fits. Throwing fits, usually the convulsions or seizures or epilepsy caused by aberrations in the brain waves. There are different waves in the brain, and the fluctuations or hyperacting areas of the brain can throw abnormality in the brain waves, and that can induce seizures or fits. So that is due to a brain pathology. When everything is normal, there is no indication of a underlying brain pathology, then it becomes psychological. Dear viewers, we talked about hysterical disorder. We don't use that term now. We call it dissociative disorder. Different aspects of it. I trace a little bit of history to talk about hysteria and what it is, what Sigmund Freud said, all those things to make you understand. And I also explained about what current concept and who treats most of this patient, which branch in psychiatry treats this patient. In our next episode, I'll be talking about psychosomatic disorder. It's a wide range of disorders, and I'll be talking about mind and body, psych and soma, and what the concept and what are the psychosomatic disorders and what are the psychiatric disorders in that area. Thank you for being with us. Do subscribe our channel, and if you think it will be helpful to others, please do share others, and see you in our next episode. Thank you. Bye.